So it's a great pleasure for me to introduce our next speaker and fellow co-convener, Dr. Samantha Ng. Sam will talk to us today about the development of the hepatitis C positive donor transplant guidelines developed here at Metro South Health. You can see that Sam's bio is only slightly less parsimonious than mine, which was a blank page. But I would like to say that Sam is a transplant nephrologist here at the PA. She has interest in education and training, and she does a fantastic job, which extends to being very patient with some of her favourite ID colleagues when they ask inane renal questions that she answers with a smile. Please join me in welcoming Sam.
Thanks very much, Lana, who also answers with a smile when I ask her about amoxicillin and other things. I'd like to talk about how I developed a protocol for deliberately infecting people at a transplant ID conference. So we'll see how that goes. The first couple of talks, very interesting. Thank you. I really enjoyed the liver talk. I was sitting there thinking about how important it probably is actually to develop protocols in our area because it's so understudied and we're all out there in our centres doing what we can. But perhaps writing down what we're doing and doing it in a standardised manner will allow us to gather more data in the future. So we know that there are highly effective direct-acting antiviral agents available now to treat hepatitis C. There is now widely available published data to show good treatment tolerability and long-term outcomes in all forms of solid organ transplantation. And this is probably an opportunity to expand our donor pool. We talked about discard rates for DCD organs already this morning, and there's high discard rates for HCV viremic organs in the States as well, even being considered for people who are HCV viremic themselves. I looked at our data when I was developing this protocol over the 2 years prior to me developing it to look for donors that we might have missed and that we could have used if we'd had some treatment protocols in place. I figured out that we probably could have used up to 24 kidneys in the 2 years prior to my developing this protocol. Since then, that probably hasn't been the case, and I think probably because people are getting treated for hepatitis C more, but anyway, it's still an opportunity, and to have a protocol in place means that we can use these organs when they come up. This is just a refresher on counselling patients. This is the TSANZ guideline on residual risk of bloodborne viruses in donors who have passed away in the ECLIPSE window for testing. So we always routinely have the ELISA and the NAT before we counsel recipients on increased viral risk donors. But I thought I would just outline the groundwork that for my HCV protocol that was already done by our original gangster transplanter, Dr. Nicole Isbell, who is one of Australia's most senior transplant physicians. So we have had this policy in place for up to 4 years. It was something that we fudged along prior to that in a non-protocolized manner. We wanted to talk about acceptability for patients. We wanted to talk about how we consent patients, how we test them, and how we follow up. We needed to iron out funding because the repeated NAT testing is not funded by Pathology Queensland for that. We undertook wide consultation with our infectious diseases colleagues, with Pathology Queensland, with our surgeons who needed to be on board with operating on people with potentially high rates of bloodborne viruses. We consulted with the Donate Life Agency, and we went on a roadshow to the wider Queensland nephrology community as well to get them on board with talking to their patients about these potential risks for their recipients. We implemented a protocol that addressed some of these issues, and in our initial iteration, the follow-up testing for recipients who have received an organ from a donor with increased viral risk, the responsibility remained with the home teams after they were repatriated from our service. So our service model here in Queensland, we're a single centre transplanting centre. So a lot of our patients come to us from elsewhere and are repatriated at about 6 to 8 weeks, all things going well. PS, the BK is positive, good luck. No, that's not what we do. We did an audit after probably the first 6 months of using this protocol, and we were alarmed. So there was much loss to follow up. There were many wrong tests being ordered. There were many tests who were being lost entirely. So we panicked and we went back to the drawing board, and we came up with a second iteration where we do it. So we have a register of our patients that who have received these organs. We have a dedicated staff member to manage the follow-up tests. The tests are reviewed by a single nephrologist from our service. And we give them dedicated PathQ forms. So again, we're a statewide service, so we have a single pathology service. They get special forms to take back to their facility and the tests are done. Since June 2021, when we formalised this process, we've had 43 recipients. In the program, one has had an HCV seroconversion, which he was adequately counselled about prior to transplantation. And when we rang him to say, your blood tests are now positive for hepatitis C antibody, he said, oh, yep, you told me about that. That's cool. Thanks so much. I'm so happy off dialysis. And we had one HBV seroconversion, which I will talk about later. So looking at I did some groundwork on prior Australian experience of transplanting with HCV viremic donors. There is a centre in Australia who is doing a trial in this area at Sir Royal Prince Alfred in Sydney. They are having huge trouble recruiting, but they have reported their first 3 cases. Everybody got hepatitis C, unsurprisingly. Some people took up to 3 weeks to become viremic for hepatitis C in their follow-up period. They had a lot of trouble getting their arms around consenting people for the trial. Kidney transplant is different to liver. Our guys go on a wait list and are on a wait list for up to 3 to 5 years before they get their organ. And you can imagine that landscape changes, people's appetite for risk changes, their lifestyle changes, their health changes. Dialysis is awful. And the things that they would accept or the things that they would not accept are very dynamic in that period. So we had some talks about how we would consent people for these organs in the development of our protocol, and I'll go into that shortly. Queensland Heart and Lung already had a policy in place when I started talking to them, and they still do, and it was a great policy, and they sent it to me to share. Thank you so much, Chandama at the Prince Charles, for helping me. They still haven't had an appropriate donor, so they haven't done one at last check, which was last month. Other centres had an ad hoc approach. So Fiona Stanley in Western Australia will consider these donors. They don't have a formal protocol in place. They kind of rock and roll on the day. They don't have anything written down. And I went to some conferences. I went to TSANZs and ANZSNs, and I made friends at posters and I picked brains. So thank you to all of those people who were very, very helpful and collegiate. This is a nice summary of the available evidence to date. It's an American study, and most of this evidence is from America because they saw an opportunity to increase donor availability in the height of their opioid epidemic, and went and studied it. So this is a little summary slide of all of the trials, or most of the trials in different organs that have been undertaken. The thing I wanted to really highlight is that there's all the different organs, there's different antiviral regimens, there's different therapy durations, but very high rates of sustained viral response across the board, which is reassuring. There are consensus guidelines now on the use of viremic donors in solid organ transplantation. And I like to say that I preempted KDIGO, but these guidelines came out shortly after I inaugurated my protocol. And you can see there, they recommend doing it. It's a good idea. And here's a systematic review that came up after the KDIGO guidelines were inaugurated. So the key points from the literature for me are that the main dichotomy in undertaking this kind of work is whether you transmit and treat or whether you undertake preemptive treatment. Both approaches are widely practiced. Both of them are widely reported on. There is great variability in detection of viremia post-transplant, and I think even the Australian cases from RPA show that. I think that's really important for us as a centre who repatriates patients to another facility. The regimens mostly are glecaprevir, preventosvir, or sofosbuvir, velpatasvir. They're pan-genotype. You can switch from one to the other if there's treatment failure, which I'll go into. And the global experience definitely shows reduced wait times and equivalent 12-month outcomes. And I'll show you from the one case that we've done that's the same for us. So our considerations were consent, and I talked a little bit about that earlier. We had to think about virus considerations, transplant considerations, logistics of repatriating these people back to their home centres on drug, and funding considerations. And then we needed to make sure that they got adequate follow-up. So the big thing for us was whether or not we infect people and wait, or whether or not we start treatment with their induction medications. There doesn't seem to be a difference in viral response with either of these approaches in the literature, but it can be a long window. And for a service model that sends people home, potentially with no viremia and no plan for being on drug, there are risks that they get missed. And in the literature, the people who had poor outcomes from the transmit and treat approach are all people who fell through the cracks. And again, that's American data where there's funding problems, the insurance pulls out at the last minute. There's poor access to transplant follow-up for solid organ transplant recipients in America in general, but these people fell away from follow-up from their transplant centre, and then that data was lost. So we thought it was pretty risky to do that. There's reports of people developing membranous nephropathy and losing their kidneys after a liver transplant where they got hepatitis C and then got fibrosing cholestatic hepatitis. So the kidneys are at risk. I said the graft function may be impacted. We need to ensure they go back with drug if they need it. And the PBS doesn't fund drugs for this purpose. So you need to be viremic to apply for funding to the PBS. This is just the PBS start. So cost was a big issue. The DAAs are it's come down actually, it's now about $11,500, but it's still a lot of money. And in the worst case scenario, we would, because of the way we decided to do this, which was that we would start with preemptive treatment, we would need to be funding up to $56,000 for a course of these drugs. There's also repeated testing for the multiplex, which is about $250, and a single genotype test, which is $173 in Queensland. I made a fancy diagram to try and illustrate to the powers that be who are not familiar with what we do as clinicians that this is what it would look like. I did a cost-benefit analysis. Dialysis is incredibly expensive, which is only good when you're trying to sell something that's slightly less expensive, but it worked. So transplant is cost-effective after the first 12 months of treatment. Transplant itself is, again, incredibly expensive. They're in hospital for a long time. They use all kinds of resources. But once they get out from that, you are saving tens of thousands of dollars to the health service per patient per year. So I did that. I served up a whole bunch of references, including Queensland Health data, to the High Cost Drugs Committee. I talked about quality of life, and they said yes. So our hospital agreed to fund the drug in the instance that they don't become viremic while they're here with us and they go back with bottles of drug in their bag. So I decided that we needed to have some form of education process for our potential recipients. This starts in transplant assessment clinic for us. So our guys come and meet us in Trans Assess, and we talk to them about all of their different risks with transplantation, and we broach this with them in Trans Assess. And there are some people who will just say, I absolutely cannot abide the thought of having that happen to me. I don't want to have tests that look like I've had hepatitis C in the future, nothing. And we say, okay, we write that in their chart. Most people say, oh, I'd probably consider that and maybe I'd like to know more about it. We write that in their chart. And we don't consent them add enrolment onto the wait list. So we believe that every organ that comes has its own attendant risks and benefits, and we counsel our recipients on the night about each and every single kidney and what that might mean for them. And that's because people are on our wait list for years before they get an organ, and things might have changed. They might have had children, they might be planning to have children, something might have happened, they might have gone through a divorce. There's all kinds of things that affect people's risk appetites for transplant. We commence our pan-genotypic DAA at induction. So one of the tricky areas, I know there's some pharmacists in the audience, one of the tricky things we ended up coming across was, when do we open the bottle? Because you can't share a bottle between patients, and the bottle, this $10,000 bottle, when do we do that? So we decided that we would open it with their 12-hour meds. So they get a bunch of induction meds before they go to theatre. They go to theatre, and by saying that we'll open the bottles with their 12-hour meds, it means that the transplant, the organ has arrived, it is usable, they've gotten through their operation, and they are going to have a kidney put in. So there was a scenario where, and we know this as transplant physicians, they get down to theatre, they take the kidney out of the box and something's happened to it and we didn't notice and it can't be used. And then we've opened $10,000 of drug for no reason. So that was an interesting little hurdle I had to get around. We genotype them during their stay. It doesn't really matter. That's for kind of interest purposes. We continue them for a full 12 weeks of treatment. There is a lot of data available that shorter durations of treatment are effective in kidney transplant, primarily because we're not transplanting cirrhotic recipients. But we don't want to take any more risks than we already are doing. So we continue the treatment for 12 weeks, and the hospital said they'd pay for it, so it's fine. And we enroll them in our increased viral risk donor follow-up, which is protocolized and which we have now good data that works. And that it used to be 12 months of follow-up. It's now shortened to 6 as per the newly published TSA and Z guideline, which is based on our guideline. So we use Epclusa, and this was a regimen that was chosen in consultation with our crusading transplant hepatologists. Thank you very much for your input. We recommend entecavir for Hep B core antibody positive donors. I'm talking to a room of transplant ID physicians, so you all know about co-infection, but we recommend 12 months of therapy with entecavir for either Hep B core antibody donors or recipients. When we are consenting people, this is in my protocol, we quote 95% viral response with a single course of DAA. The real life value is closer to 99%, and the literature suggests 100%. The very few reported cases of resistance, you either extend the treatment out to 16 weeks or you change to another DAA, and that's all been highly effective. There hasn't been any reported cases of treatment failure in the kidney transplant population. We do post-operative NAT testing very frequently, and this is, again, a cost-benefit offset. So this is to try and find virus and offload the cost of the drug onto the PBS from my hospital. Again, we decided that that was the best way to get through this. I have a flow chart in the top of my protocol. I think I wanted to tell this story from the perspective of developing a protocol that helps your colleagues do things. So this is my flow chart. Dr. Cho wanted me to put this in at the top because we're doing this at 2 a.m. And we're tired and bleary-eyed and we just need to know what the steps are. So here you'll see in a second box there is a guideline on considerations for consent, which you can read through. Here's my special PathQ form that is also in the protocol and you can print out also in the second drawer of my desk if anyone needs it. This is our the guidelines that I wrote on counselling and consent for these procedures. You don't have to read it. I just put it in there because I think it's important to have that in there when, again, it's 2 a.m. and you might need some help talking to patients about this. I was lucky enough to be on the joint TSA and Z ANZSN transplant education working group, which had some real experts on consent. They were academic experts on consent, and I was able to, I don't think I contributed to the working group in any way, but I was able to listen to them and to their research about consent. And it was really lucky that it coincided with when I was talking about this and really helped crystallize to me what I said, which was that people's appetite and lives change over such a long period. Pre-consenting people for something like this, which is what all the other centres that are doing this in Australia do, means that these people may actually just miss out on things that would benefit them, but because time points are different, lives are different, they're not considered. And I think that's a real disservice to them. So that was the other part of my consent diatribe. I made some little flyers that you can download from our transplant protocols website, which is available to anyone who's interested, that you can print out and give to your recipients if you are a treating nephrologist. Here are some resources that you can use to read, if treating nephrologists can use to read about hepatitis C. So our first outing was last year. It was a 37-year-old man. He was blood group O. He's unsensitized and he'd been on dialysis for 8 months. Blood group O, unsensitized, on dialysis 8 months means this boy probably had another 5 years of waiting time before he got a time wait offer. There are mechanisms in Australia to have access to a kidney sooner than that on the basis of matching and young age, but by far the majority of kidneys that are allocated in this country are allocated on time wait. So this is a young person who's trying to be a productive member of society on dialysis. It's very hard. You can see here, so the KDPI is 21, which is you can get me started on this, but it's a sort of a measure of the quality of the kidney. It's a very high quality kidney. It's in the top 20% of the last few years of kidney quality. And his EPTS is 9, so that's his estimated post-transplant survival. Again, he's a very high quality recipient. He received a very well-matched organ, and he received this. He came up on the national list because this is a very well-matched organ for him, but he was not number 1 on the list. This was a young DBD donor. He died of a drug overdose. The terminal creatinine was 40, which is excellent. Had a high viral load, genotype 6 hepatitis C. He was also core antibody positive, but surface antigen negative and NAT negative. The kidney had been offered elsewhere first and had been declined because the other centres didn't have a program to do this. So we came to the rescue. Our recipient had not had any conversations about this prior to being offered the organ at 3 o'clock in the morning by one of my crusading colleagues. But I'm going to toot my own horn. She said she read my protocol and she thought, you know what? This has given me a good framework. I'm going to ring this kid up and see if he wants to do it. And he was able to have a very good conversation with her over the telephone and accepted the organ in a heartbeat. He had detectable viremia at day 1. Hurrah. So we didn't have to pay for really any drug at all. He had undetectable virus by day 3, and his 1 month and 6 month core antibody remained negative, and he actually never seroconverted. He never seroconverted. He tolerated the drug very well. He was commenced on entecavir per our protocol, and I put that in the obviously you put it in the protocol because the prescribing guidelines for the DA say you should, and there is data to show that, you know, co-infection is something that you need to be aware of. I threw it in there because that's what it's said to do, but I'm really glad I did because he actually seroconverted to Hep B. And we didn't expect that. And Hep B serology was not part of our post-transplant screening. We had Hep B NATs, but we didn't have serology in our protocol, in the increased viral risk donor protocol. And the reason we even found out about it is because somebody ordered the wrong test at his home centre. So then this is his creatinine. So he did really well. He's got a beautiful functioning kidney and is feeling very well. But we all panicked because we thought, oh my gosh, what have we done? Have we given this kid hepatitis B? Have we not? So I went for a little wander through the literature. And again, you're all transplant ID physicians, so you know more about this than I do. The postulation is it's either a competitive replicative environment and you know, the viruses are transmitted largely in the same way. Back in the day when Hep B core antibody positive donors were the controversy and were being considered, and this was in the early 2000s by people who are now very senior colleagues of mine, the NATs were not as sensitive as they are now. So they're much better than they used to be. So the other postulation is that there was passive antibody transfer from the donor to our recipient. It's also possible that we just gave him a bit of hepatitis B and then made it go away with the entecavir. At any rate, we've added serology into our viral risk donor protocol now. So that was how we revisited that. Final thoughts. I am also the chair of the Young Nephrology Committee for our country. And one of the things that I really liked about doing this is kind of a big project for me, and it's meant that I can come and talk to other colleagues about how we've done something. And I met lots of new colleagues and collaborated with them along the way. So it was, as a young nephrologist and someone who's new to being a consultant, I would really encourage anybody else in the room to say yes to doing something like this. It's a really great thing to do for your career. I took surgical goodwill for granted in this. My surgical colleagues here at the PA didn't bat an eyelid when we said we'd like to look into doing this. They thought it was a great idea. They wanted to help us do it. In talking to other colleagues from other centres around the country, that's not always the case. And there are surgical colleagues who have real concerns about operating on actively viremic donors, and their policies and protocols have stalled in that setting. So I'd like to thank my surgical colleagues. They're not here, but I thank God for them every day. But today in particular, that was a really stellar part of this. I forgot to tell public health that this is what we're up to. Sorry, public health. I got a call and they had forms to fill out. And I had to apologise, and then I sent them my protocol and said, sorry, it was deliberate. We deliberately gave this person hepatitis C. That's a hard thing to say as a physician. Don't underestimate the patients. They really want to hear about ways in which they can increase their chances of boosting their health. Kidney recipients in particular, these guys are on dialysis for a long time. Dialysis is an incredibly burdensome treatment, and lots of treating nephrologists perhaps were like, oh no one will say yes to that. I have to say, anecdotally, in my experience, everyone's really willing to talk about it, and people are very reasonable about considering risk like this. I got, as I said, really lucky with learning about consent and really formal and academic approaches to considering consent for patients. Again, that was just luck. I put my hand up for something and I ended up being able to use it really effectively. So thanks for letting me have my young ANZSN hat on as well, and I'm happy to take any questions.
Thank you very much, Sam. How are we doing for time, Louise? Have to keep me. Yeah, okay. But I just wanted to say it's a rite of passage, Sam. You do say that you're a mini ID physician. Forgetting to tell public health something is pretty much the standard for ID training at least once. Thank you for a fantastic talk and for presenting that enormous amount of work that you did and a pioneering effort by the sounds of it.